Bismillah ar-Rahman ar-Rahim. I'm Mahmoud Ali, a pediatric cardiac anesthesia fellow, and I would like today to talk about one of the congenital heart disease lesions, which is the atrioventricular septal defect, or the AV canal defect, or the endocardial cushion defect. All are the names for the same lesion. So because it is a big topic, I will divide it into two presentations. The first will be about the lesion and the pathophysiology, and the second will be about the anesthetic management. If I have done any mistakes, please forgive me, and you can correct me in the comments, and also forgive me for any English mistakes. I am not a native English speaker, and I predict that I will do lots of them. When talking about the AV canal defect, the first is to try to classify this defect into its three types. It is usually classified into complete AV canal defect, partial AV canal defect, and transitional or intermediate defect. Just looking at the normal heart here, the normal heart, I will just highlight where the endocardial cushion usually work. I mean, which part of the heart will be formed by the endocardial cushion. So this part of the heart that will be formed by the endocardial cushion, which includes the lower part of the premium interatrial septum, the inlet part of the ventricular septum, the septal leaflet of the tricuspid valve, and the anterior leaflet of the mitral valve. If this area is missing, so what we're going to expect from this patient? So this patient will have premium atrial septal defect, inlet ventricular septal defect, and those two valves, the mitral and tricuspid, may be just connected together and they become just one valve. So these are the types. Type A here is the complete AV canal, where we have communication between the two atria and the communication between the two ventricles, and classically these communications are big and non-restrictive, and just one hole separating the upper part from the lower part of the body of the heart. So this is called common AV valve. So this common AV valve is like the two original valves, mitral and tricuspid, becomes like open together to make just one valve. So the valve will separate the atria from the ventricles during systole, and when this valve is open, all the four cardiac chambers are open together. So this is a complete AV canal. For the partial AV canal, for some reason, the defect in the septum, in the ventricular septum, is closed. So we will have, in this situation, a premium atrial septal defect, this one with a communication here, but we don't have a communication between the left ventricle and the right ventricle, but still, and also this AV valve, common AV valve, now has two orifices. So we can say at this time we have left AV valve and right AV valve. We cannot say that this is mitral and this is tricuspid, because they are completely different and completely abnormal valves. So we call them, this is the left AV valve and this is the right AV valve. The partial AV canal can also be like closing the ASD and keeping the VSD. So the common AV canal and its leaflets become stuck to the interatrial septum, so it closes the communication between the two atria, but the communication between the two ventricles is still there. This is a very rare form. The common form of the partial AV canal is the one that keeps the ASD and closes the VSD. The transitional form is something like the complete AV canal, but this communication between the two ventricles is restricted by some tissues, some chordae from the common AV canal that managed to make some restriction here of the flow from the left ventricle to the right ventricle. So it is not a big non-restrictive defect as the patient with the complete AV canal. So these are the types. This is a picture to show the classification of the common AV valve. When we have a common AV valve, there is a classification called Rastelli, Rastelli A, Rastelli B, Rastelli C, and this is according to the arrangement of the leaflets of this common AV valve. As I said, this is not two separate valves. This is a big valve with different organization of the leaflets, and usually most of the patients will have some regurgitations through this valve, and this is of significant importance. I just want to highlight here, I will just give the name of one of these leaflets which is of significant importance to us. This leaflet here is called the left mural leaflet, and this left mural leaflet is of significant importance because when this leaflet is small, when the surgeon starts to repair this valve, it is really difficult to stop the regurgitation and not making stenosis. So this patient can have some residual regurgitation after, and they can have some stenosis after. But when this latter left mural leaflet is big, this makes the mission of the surgeon easier and the results will be better. I just want to also to highlight the difference in the position of the aorta in a patient with AV canal. So this is a cross section of the heart, showing the heart from the atrium looking to the ventricles. So this is mitral, this is the tricuspid, aortic, and pulmonary. Usually the aortic valve manages to be moved a bit posteriorly and being wedged between the mitral and tricuspid valves. This is the normal, but for a patient who has common AV canal, the communication between the two valves, the left and the right, there is no chance for the aortic valve to be wedged here, so the aortic valve has anterior position in those patients, and this is of significance that will appear in the next slide. This is this is a normal heart. So in the normal heart, we'll find that the distance between the mitral valve and the apex is almost equal to the distance between the apex and the aortic valve. So the left ventricular outflow tract, or the flow of blood from the left ventricle to the aorta, does not need to go for long distance in the normal patient. But for a patient with AV canal defect, because of the inability of the aorta to be wedged in the normal position, the position of the aorta anteriorly than normal, this makes that distance or the flow of the blood from the left ventricle to the aorta goes through a longer LVOT, and this LVOT is more vulnerable to obstruction. Also, we have something that we can find in the AV canal patients, which is like shifting of the atrial or ventricular septum to the left or to the right. The less important is the deviation of the septum at the atrial level. This can end in two forms: the double outlet right atrium and the double outlet left atrium, and this will be clear in this slide. So if we have intraatrial septum that was shifted to the left, so we have a big right atrium and small left atrium, and this right atrium is like facing both ventricles, so we say this is double outlet right atrium. And on the other hand, if the septum is shifted to the right side, so we have a small right atrium, big left atrium, and the left atrium is facing both ventricles, so we say this is double outlet left atrium. The more important is the shift at the ventricular level. If we have a patient that has its septum, ventricular septum, shifted to the right, so in that case most of the blood coming from the right atrium and left atrium will go to the left ventricle, and the blood going to the right ventricle is less. So this right ventricle may be small, may be hypoplastic. On the other hand, if the septum shifted to the left, so we have a big right ventricle, like accommodating the blood coming from the both atria, and the flow to the left ventricle is less, so this left ventricle may be hypoplastic. And this is of significant importance, because if this left ventricle is too small to be able to push against the systemic vascular resistance after closing this defect, so this patient may not be for the normal repair with one graft or two grafts of the ASD and VSD, and this patient may take another pathway, which is a single ventricle pathway. So we have now a patient with common AV canal, and we'll see in the echo that the cardiology said it is a balanced AV canal. That's good. If it is unbalanced AV canal, I will see is it right dominant or left dominant? Is it right ventricular dominant or left ventricular dominant? And how is the other ventricle? Is it hypoplastic or is it of a good size? How this patient will present? So like any left to right shunt, this patient will have a high pulmonary blood flow, and if this shunt is severe, this may affect the blood flow to the systemic circulation. So the high pulmonary blood flow will cause a wet lung, so the diffusion of oxygen through the alveoli in the lung will be affected. So the child may be with increased work of breathing, and if the child has increased work of breathing, he is like consuming all the caloric intake he has just in the breathing, so this child will not be able to gain weight. Also, the increased work of breathing will prevent the child from getting his feeding, so it will affect the growth and the gaining of weight as well. So increased work of breathing, failure to gain weight, and recurrent chest infection because of the wet lung. It is not common to have a patient with a poor ventricular function to the extent that this patient is not able to compensate for the stealing of the blood from the systemic circulation. Usually the ventricle can do much to increase the cardiac output, so to compensate for the decrease in the systemic blood flow, but for some of those patients with severe VSD, severe shunt through a big VSD, this can steal from systemic circulation, and the patient will present with low perfusion symptoms or signs. Also, this is much more to happen if this patient has a significant regurgitation through the valve, the common AV valve, because in that case the ventricle will contract, most of the blood will go through the VSD to the pulmonary circulation and will be regurged to the atria, so the blood going to the systemic circulation will be much less. So this patient may present with shock, high lactate, head to the kidney, head to the liver, and head to the intestine, and most probably this patient will be in the intensive care, intubated and ventilated and on support. Factors that can affect the presentation of and the management of those patients. So if I have a child who presents like in the first few days of life or presents very early, this is like a severe form, very severe form of the disease, because usually the pulmonary vascular resistance of the child is high in the first month or two, and this high pulmonary vascular resistance protects the lung from the effect of the increased pulmonary blood flow at this age. So if a child presents very early like that, that means the lesion is very severe, or the patient has severe regurg in the valve that cause ventricular dysfunction and shock and failure. Usually after the first 1 or 2 months, the pulmonary vascular resistance drops and the blood flow increases to the lung, and the lung becomes wet, and the patient starts to have increased work of breathing and failure to thrive and failure to be fed. The severity of this is according to the type of the lesion. Is it partial AV canal or severe or complete AV canal? And if is the VSD defect, is it restrictive or non-restrictive? For a patient who just has atrioseptal defect, partial AV canal, and the VSD is closed, there is no communication between the ventricles, so it is just some volume overload on the right side of the heart and some more volume of blood going to the lung without higher pressure. So this patient is most of the time he is asymptomatic or can present very late in life. But if we have a VSD or complete AV canal, that means it is a high volume of blood going to the lung together with a high pressure transmitted from the left ventricle to the right ventricle to the pulmonary circulation, and in that case this patient is more liable for early development of high pulmonary vascular resistance, because the lung will start to protect itself by causing vasospasm in the media and later by causing irreversible changes in the wall of the blood vessels of the pulmonary circulation, which increases the pulmonary blood pressure and the pulmonary vascular resistance. So this can happen very early in this patient, maybe in the first year of life. That's why we need to correct those patients very early, maybe like 3 months of age. Of significant importance, if we have a regurg in a significant regurg in the AV valve, because as we said, this can affect the function of the ventricle, very severe overload and dilation of the ventricle and ventricular dysfunction early in life. The balance, is it balanced or unbalanced AV canal? This is of significant importance and it can change everything. Also, there is common associated lesions that can present by itself and it changes the presentation of the disease. Me as anesthetic, the understanding of the problems in this patient can help me so much to tailor my anesthetic management of this patient pre-op, intra-op and post-op, and to have a prediction of the problems and issues that I will see in this patient. So I will enumerate, or I will go through these problems, and in the next presentation I will see how we're gonna modify our anesthetic management according to the presence or absence of these problems. One of the most important problems is the regurg through the AV valve, which can lead to the second point, which is ventricular dilatation and dysfunction. So I need to see the echo and see how significant is the regurg and how is the function of the ventricle. Another thing is the unbalance, or is it balanced AV canal or unbalanced AV canal? And if it is unbalanced AV canal and we are planning to do a full correction closing the ASD and VSD for this patient, is the remaining or the other side ventricle is big enough to take over and push against the circulation after doing the repair? The common one is the right dominant unbalanced AV canal, so that means the left ventricle will be small or hypoplastic. So is that left ventricle will have enough function and volume to take over when we close? This is of great importance. Also, the associated lesions, I want to know what are the associated lesions. So this patient may have TOF, may have coarctation, may have ASD, may have PDA. Of significant importance is the abnormalities in the conduction system in those patients. For this, I will go back to a previous slide, the normal heart. Usually the AV node is somewhere here and the His bundle will go this way and it will be branched to supply the ventricular muscles. So the AV canal defect is here, is taking this area. So the AV node has to find somewhere else to be, and His bundle has to find another pathway to go to reach the ventricles, and this pathway is usually much longer than normal. So this bundle and this node is very liable for injury during the operation, and the patient may end up with heart block, and I need to be aware about that. So back to the other important points affecting the anesthetic management. So if this patient came to us early, so we are not expecting the pulmonary vascular resistance to be high at this time, but for example, if this patient is in a developing country and there is no antenatal diagnosis, so this patient diagnosed late and this patient has this left to right shunt for a long time, so I may expect that this patient may have a high pulmonary vascular resistance. So for this patient, a cath lab may be indicated, and according to the result of the cath lab, the management plan will be. So if this patient has a high pulmonary vascular resistance, so this patient may be not for a complete repair of the AV canal, because this patient will not be able to tolerate this pulmonary vascular resistance. When I close the septum, the atria and ventricular septa, the right ventricle may not be able to push against this resistance, and the right ventricle may fail immediately on the table. But in case we have pulmonary vascular resistance in the cath lab, which is normal, this is good, so we can go for the repair. If we have a pulmonary vascular resistance that is high, but it is responsive to oxygen and nitric oxide, so in that case, that means this patient is amenable for repair, but we need to be cautious because this patient will have a hyperactive pulmonary vasculature, which can be very sensitive to any noxious stimuli or any sympathetic stimulation. The last point in the problems is the LVOT obstruction. Do I have obstruction at the level of the left ventricular outflow tract in the echo? Because this will affect my anesthetic management. I hope that's useful, and thank you very much for your listening.